We're here with Dr. Norman Hoffman. Dr. Hoffman is essentially our pain educator here at the Carrick Institute, and it is currently Pain Awareness Month, so we wanted to interview Dr. Hoffman and get his ideas on pain awareness. And anybody that watches any of these video clips, we want them to try to get a little bit more awareness of what actually pain is. So here we go. First question, statement first, then I guess a question. So pain is often described as the body's alarm system. So from your perspective, what exactly is pain? And how should clinicians think about it beyond just a symptom?
Wow, that's that question we could answer for the next hour.
Yeah.
I mean, there's three types of pain, right? There's nociceptive pain, there's, neuropathic pain, and then there's neuroplastic pain, which is, we've got acute pain, we've got chronic pain. Acute pain says, hey, there's something wrong over here, right? You should do something about it. It's the nociceptive system. And you say, hey, there's a problem. You do something about it. Chronic pain doesn't mean anything with that. It has nothing to do with whether or not there is substance P at the receptor site where it hurts. It doesn't mean that there's something wrong there that you can fix at that site, because the whole central system has become sensitized. So we talk about central sensitization, and central sensitization means you've changed the underlying structure and chemistry within the spinal cord, within the brain stem, even the brain, to make it easier to have pain. And so even little things become explosive. The tiniest little, and it doesn't even require anything. There could be pain for no reason. There's no definitive sensory input, and yet it hurts just all the time. So fibromyalgia patients to whatever, you have patients that are suffering and there's no clinically defined reason for that. And that's why it becomes medically confusing. That's why it's difficult. That's why nobody seems to know what to do about it. When you read what you should do about chronic pain, it all comes out with psychology, right? It's all the psychologists is this, you should be doing cognitive behavioral therapy. And what that tells me is that fundamentally most doctors don't understand what they can contribute to the chronic pain model and how they can help these poor patients. And we're just going to send them over here for that. But it also tells me that the brain is involved. If the best thing that modern science has is cognitive behavioral therapies and the brain is involved, well, shouldn't the brain be our playground as functional neurology practitioners? Shouldn't we be able to do something like that? And in fact, we can.
Yeah. Pain is like the body's alarm system, but sometimes it's a true alarm, sometimes it's a false alarm, almost like the check engine light in your car. Sometimes there's something wrong with your engine, sometimes the gas cap is loose, right? So yeah, so the reality is that it can be telling you that there's some substance P, there's some nociceptive signaling going on there. Other times it could just be inflammation or something with the central nervous system that feels like pain, but there's actually no nociceptive pain or reason to have that alarm system on.
You talk about chronic inflammation or whatever, there's nothing happening. There's no tissue destruction. There's not, there isn't damage to the muscle at this point. There's no inflammatory processes happening where the pain is occurring. The pain is coming from somewhere else.
Absolutely. That's a great distinction. So that kind of leads us to our next question. So chronic pain often doesn't show up any type of imaging or lab work. How does that invisibility affect patients and the clinician trying to help them?
Well, it frustrates clinicians. It frustrates patients. I mean, the research on patient satisfaction with their care in chronic pain, it's like abysmal. And it's the same thing is true for doctors. They don't want to treat these patients. They don't want to see them because they're frustrated because they don't seem to be having the ability to help them the way they want to. Opioids certainly aren't the answer, but it's kind of, they try this and they try this and they try the gabapentin and then they try this. And if it doesn't work, they're like, it's what I got for you. Oh, we could try some SSRIs and what, that they try to do something, but it doesn't work well. It's very poorly treated. So everybody loses. The practitioners are miserable. The patients are miserable. It's because they can't find that structural thing like you were talking about.
So how can they find the pain source?
Yeah. So in our course, we try to teach you how to identify the sort of layers that we need to go through in terms of treating a chronic pain patient. So it depends on what you're dealing with. But we've taken the best research that says this works for this type of a patient. And then we have the ability to do these sort of procedures that allow for the patient to have a different sensory experience. When you're talking about these types of chronic pain patients, it's very rarely that you need to identify a specific part of the brain that you need to identify or that sort of a thing. Sometimes that's the case, but most of the time not. And that's why it's tricky, because if you follow a traditional functional neurology model and you map all the eye movements and you do everything that you would normally do and you get them on a balance, posture analysis and all this sort of stuff, you don't necessarily see anything that fits a clinical signature that you can say, I do that. And then if you do that, that the pain helps. It doesn't really work. But that's not to say that you can't help. What you do is you do these specific sensory changes that go through the different levels. Let me show you why that matters. And then the patients start to have a different integration of sensation in their experience.
Perfect. That's brilliant. So you've been in practice now for 30 years or so. You've earned a Master's of Science in Clinical Neuroscience. How has that journey shaped your work with pain and complex cases?
Honestly, the first 20 years, I really didn't want anything to do with pain whatsoever. I mean, as a chiropractor in practice, you're going to see pain patients. Obviously, that's who's going to seek you out for the majority of people that are looking. Yeah, you get the wellness patients every once in a while and you cheer. But I was a straight chiropractor-ish, the best that I could be in terms of my chiropractic philosophy. And then I take the neurology program and I'm integrating all of this stuff into there. And I'm going to deal with all of these neurology things. And I'm still staying away from pain because I'm going to let the physios handle that. And the other chiropractors can have that. And they can have the low back pain and they can have the neck pain. And I don't want it. And then I made a slight little shift in my practice. I added a machine in that I thought could help with tissue healing. And I put out a little feeler for, chronic pain patients. And they came in droves, and I had to deal with all of these patients that were coming in chronic pain. And the conversations that I was having with them were like heartbreaking. The frustration, the lack of help, the number of people that they've seen, and everything that was just devastating. And I was able to help them, and they got better. And it was one after the other. And I was just like, okay, so clearly it's not out there. Clearly there is a disconnect in helping chronic pain patients. I gotta figure out how to get the tools into the hands of the practitioners so that they can help these people so that they're not just out there suffering.
Yeah, absolutely. Makes a lot of sense. So let's kind of transition maybe into some of the education that you offer. So we kind of talk about techniques for peripheral and central dysfunction. And many clinicians are really familiar with the receptor-based approach, where we look at sensory information and, we evaluate how the sensory information is being processed. What makes this program such a powerful tool in somebody's practice?
It allows you to quickly be able to assess that sensory input from a motor perspective. So you're going to see what's the baseline motor output. Test all the different actual motor pathways, see what they're doing. If they're, something's wrong, this pattern shouldn't be doing this. This shouldn't be weak over here. This is overexcited over here, and I can't get it to be weak for nothing. The pattern is not healthy in one way, shape, or another. Then we can integrate all of our receptor-based modalities. We could use eye movements. We could use vestibular stimulation. We could use color. We could use smell. We can do whatever and see what changes in these motor output patterns. So it allows us to be able to say, what is the state of the patient? If I do something from a receptor base and I put input in and it changes, what happens as it comes out? And it allows us to be able to quickly identify patterns that might say, this is a nerve entrapment of the radial nerve. No, this is a C6 disc. No, this is a pontine pattern. No, this is a limbic pattern. No, this is a frontal lobe pattern. And so we can easily identify that same sort of looking thing on the outside, I can see where it's coming from. Patient comes in and they've got their, say, slightly off balance. We might be able to assess, is this primarily a weak motor pattern in a leg? Is this something that's coming from the cerebellum? Is this a pontine integration system? Where is it coming from? Where they've got numbness in their arm, where is it coming from? What's going on?
So it's taking that sensory motor integration loop and not only focusing on the sensory portion of it, it's really looking at the motor portion of it. So it's almost kind of like, a detective going to a crime scene. These are all the clues. This is all the evidence that there's something going on. and it points in the direction of what actually the problem is. I mean, it'll tell you things that are not a problem. It'll tell you things that are a problem. Does that sound about accurate?
Yeah, absolutely. We need to be able to say everything that the brain is doing, everything that the brainstem is doing, everything that the cord is doing, it has a motor consequence. And that motor consequence is so beautiful, but it's complicated. It's not straightforward because it's integrated with multiple different centers. And so you have to be able to sift through that and go, is it this? Is it okay, then and follow the algorithm so that you can identify what's creating that change in motor pattern.
And if you don't know those pathways, you're just missing a whole lot.
You're going to make the same assumption that everybody else makes, and somebody's got a numb arm, and I'm going to adjust C6 because that's where it's coming from. That's just what it is. If you don't know the other options, you can't even look for them.
Yeah, you're basically just ignoring clues. You're leaving them on the table that's going to point you right to where you need to do your work.
Absolutely.
So you emphasize in your program that no special equipment is needed for any of this, just your hands. Why was it important to make this practical, learn by doing sort of a program?
Well, because wherever you're at in your practice life, you'll always still have your hands. So you need that fundamental tool above anything else. And yes, in the pain programs, we do teach how to use various tools for everything like that. But you also need to be able to start with, like, what can anybody do?
Yeah.
What can anybody do, right? If you're identifying a nerve entrapment problem in the course, you can unentrap that with your hands, or you can adjust there, or you can do whatever you need to. If you're not a chiropractor, I can teach you other ways that you can do things that will still offload the nerve and still get you the results that you need to get to. And if you're in the pain program, I still need you to be able to understand how the sensory integration pathways go, what C-tactile fibers are, what kind of, touch that you would use in this particular patient, and what you can do to change things. And then there's tools that you can get. There's neuromodulation tools in the pain program. There's tools for repair of tissue. There's tools that we could use to upregulate things like myofascial release that are, electric. There's just all kinds of things that we can do. But fundamentally, I want to make sure everybody has something that they can walk away with.
Yeah, so like anything in life, you don't need tools to do anything. They just make your life easier.
Absolutely. You don't need a fork, but I mean, it's nice if you have a fork.
Exactly. Well, you kind of talked about your pain program, so let's maybe go in that direction. So mastery of chronic overlapping pain conditions. So conditions like fibromyalgia, migraines, IBS, those are all notoriously difficult to treat. So why are they so misunderstood, or maybe even mismanaged?
Well, they're mismanaged because they're misunderstood, and they're misunderstood because there's not a lot of there's no diagnostic markers. That's what makes them a COPC. So chronic overlapping pain conditions has been coined. The term been coined by the NIH as this grouping, this clustering of 10 different conditions, and we cover all 10 of them in the COPC course. So the chronic pain course is handling all 10 of these throughout the different modules. But they're difficult because there's nothing to see on an MRI. There's nothing to see on a blood panel. There's nothing that you can identify that says, that's it. That's where the pain's going. Even if you saw the bulge disc on the MRI, doesn't mean that's what the pain felt. I have patients all the time. They come back with their MRI results, and they says, this bulge at C5 is causing the problem in their right frame. It's encroaching in there. And they're like, but it's my left arm that's numb. Okay, well, that's not the problem, is it? So, when you've got no imaging that shows you anything with these chronic pain patients with their fibromyalgia, chronic fatigue, IBS, there's no imaging to give you anything. There's no blood test to give you anything. What do you do? If you're a medical doctor, there's serotonin reuptake inhibitors. There's nothing that really kind of addresses those problems, and they're all fraught with side effects.
Yeah.
So what we teach is the fundamental physiology of each of the conditions, what we know about what's going on with them. Obviously, we don't know everything, but here are effective strategies that can get us to where we need to get to. And when the doctors that have taken this course put it into practice, they come back to me and they say, that revolutionized my practice. Like, I cannot believe how much better I'm doing. On the very last course, we teach on the chronic low back pain program. And one of the things I do when I'm introducing the program is, you're probably good at low back pain. You probably get 80% of your back pain patients better. We're going to help you with the other 20%. After the course is done, I get an email from a doctor says, I'm already helping the other 20%. It's pretty beautiful when you get those kind of responses, right? That's the ticket. There's stuff that, you can just sweeten the sauce with.
Yeah. One of the things you actually talked about, you hit on like an SSRI, that helps a lot of people, but it's kind of like putting a Band-Aid on something. It's, becomes a situation where you have a hammer, everything becomes a nail, or maybe, you're a chiropractor and you have a screwdriver, everything becomes a screw. Your screwdriver is your adjustment where your hammer is your SSRI. We know that sometimes they work, most of the time they don't, but your program covers things a little bit different. You cover everything from manual therapies to neuromodulation to mindfulness. So how does that integrative approach change or improve patient outcomes?
Well, you have to do things that other people aren't doing if you're going to get results that other people aren't getting, right? Like that's fundamentally the difference. Is the program is research-based. It's not, Norm was doing this in practice and I'm going to teach you how to do this. I mean, taking the master's programs through the Carrick Institute, best decision I ever made as far as being able to take my understanding of things to the next level. Not even because of what I learned in the program, but because of my skills that it gave me that allow me to look into the research and be able to look through this. So I'm using those skills and I'm plowing through all of the research and pulling out all of the bits and pieces that allow the doctors to have the best influence. So we'll go through supplements and we'll go through, manual programs that go through, say for a fibromyalgia patient. We teach a type of myofascial release that has outstanding clinical outcomes. And I tell you what not to do with these patients, because I'll tell you what, most fibromyalgia patients do not respond well to a manual Rackham and Stackham type of adjustment. They just don't. Yeah. It either makes them feel worse and they just disappear, or there's not. And the research proves that out. There really isn't. You look at the research on chiropractic and fibromyalgia, and it doesn't really help a ton. But there are things a chiropractor can do that are close enough in the vein that really do work. And all you need to do is just know where they are and how to do them. One of the tricks that I do is you want to train the entire nervous system on a sensory reset. So I'll actually do the entire spine, all the fascia around that, upper extremity, lower extremity, cranial, facial, gut, ribs, everything. I do it in a 2.5 minute visit. I'll teach you how to do all of that. So my fibromyalgia, my chronic pain patients, my chronic widespread pain patients, and chronic recurrent pain is different than chronic pain, which is different than chronic widespread pain. So if you got chronic widespread pain, we're going to do everything. You're going to get something from top to bottom. And one of the reasons that that's fantastic is because if you've ever had a fibromyalgia patient come into your office and try to treat them, and you do your thing, then they go, but it also hurts here. And so you do that. And then they say, but it also hurts over here. So then you chase that one. And you're ending up 15 minutes into this visit with them just finding one more thing for you to keep working on.
Right.
And when I do it, I do the whole body in like 2.5 minutes. I get them top to bottom. And when they're done, I've hit it all. I've hit everything. And it changes the way that their central state changes because it takes the defenses down. It turns the volume knob down on their central system. We do it in the right way, and it works very, very well.
So central sensitization and glial cell activation are big topics in your course. Can you explain how they drive chronic pain and how can clinicians address those things?
Yeah, so central sensitization means that either the cord or the brain has upregulated the pain perception program, the pain perception pathway. And so we get upregulation of NMDA receptors, we get downregulation of mu-opioid and cannabinoid receptors, so you can't block pain, but you feel it even more, and the whole system is just jacked. The volume, we always say in the court, the volume knob's turned up, right? Glial cell activation is part of that neuroinflammatory process, and it usually, what my findings are, it's focal to the part of the brain that is going to be more reflective of whatever symptomatology that patient is coming up with. So we might see high amounts of neuroinflammation associated with the insula in a fibromyalgia patient, but we might see different areas with a chronic migraine patient. We might see different areas with a chronic fatigue patient. That might be more this area. And from a treatment standpoint, neuromodulation? Are we going to laser? Are we going to use vagal stems? Are we going to use trigeminal stems? Are we going to use gut? I do like a whole thing on visceral manipulation and how to use the abdominal fascia and how to work on the valves and how to work on all that stuff. And that's going to have a huge influence for an IBS patient or chronic pelvic pain patient, vulvodynia patients, all these patients that are having this type of an issue, but it's also going to have an influence because we know that 90% of the vagus is up, right? So it's not what's coming down, it's what's going up. So if you change all of this, that's going to change brain too.
Absolutely. So for clinicians who feel stuck with like these mystery pain patients where imaging don't tell you anything, labs are not providing a whole lot of answers, even their physical examination might not be revealing a whole lot, what's a key insight that you want them to take away from this conversation?
If you can identify a nociceptive pain generator, fix it, right? Find those pain generators, those nociceptive pain generators, because that's going to make their quality of life better. Once you've cleared all of that, you really have to find another way to provide sensory input into the body that it will accept, that it will consider safe, that it will drive the brain to calm down and turn the volume knob down. So there's not a magic pill I can give you on this particular thing, but take the course. It's going to be brilliant because you're going to be able to identify this, and this that you can do, and it will calm the system down. And the more of those things you can do with the patient, the better results you're going to get.
So it sounds like find the thing in the periphery that could be causing the central problem, and also cause a central problem that can cause the dynamics in the peripheral system.
Yes.
The chronic overlapping pain course, it's almost like, okay, yes, we already took care of all those things, but now this pain generation might be like a hallucination. It may not be anything in the peripheral system that's wrong. It may not even be anything in the central nervous system, like a tumor or something like that. It literally might be dysfunction of the central nervous system manifesting this phantom-like pain. And the treatment there, the approach should be there is you got to fix the brain. And you got to fix the inflammation, and you got to fix all of the other things that are causing that, what I'm calling a hallucination. How far off am I?
Yeah, I mean, I think that the danger in calling it a hallucination is that, the pain is real. The signaling is happening into their pain receptor parts of the brain. Absolutely. The pain is 100% real. It's not in their head. And I think we need to make sure that that's clear.
Sure.
I know that's not what you were saying, but I just have to say that out there because the pain is very real for them, but there's no identifiable biological source. Yes. So that is the thing. We find that the dorsal root ganglia can be sources of this. We find that the dorsal horn can be sources of this. We find that the brainstem is a huge source of this. So unlike our other methods that we use in functional neurology, it isn't about finding the part. It's about finding the ways to change the integration of the system.
Makes perfect sense. Yeah, and you talked about functional neurology. So how do you see functional neurology reshaping the future of pain management over the next 5 or 10 years?
I would love to see enough doctors take this program that the knowledge becomes widespread, that we become the go-to people for chronic pain. I love psychologists. If there's any watching this, I'm not an anti-psychologist, but I don't want the psychologists to be the only ones that have a foothold in the chronic pain world, because there's so much more that we can do as functional neurologists. We can help these people. We can change their lives. The people that have taken the program, they tell me, they write me letters about how they've changed all the patients and how wonderful it is for them. You can do this, and you don't have to be, the smartest. You don't have to be the best. There's not one person that can do this. We can all do it. You just have to get all of the systems into your head and figure it out. And once you've got that, you change people's lives. And I would like to see, you've got chronic pain, you go see a functional neurologist. That they know how to handle this sort of. That's the dream.
Yeah, absolutely. And it's not necessarily taking over the party, but at least getting a seat at the party, right? So if you have knowledge in this area and you have expertise and you get the outcomes, you'll get an invitation to the party of chronic pain management, at least a seat at the table, so that you can contribute.
Yeah, so you can have a discussion about other options other than opioids and SSRIs, right?
Exactly. Well, that's a great hope. And I think that's a reality if we get everybody up to par on the education and understanding and the mechanisms, and also a good toolbox to be able to address this.
And it makes practicing more fun when you're not afraid to see patients that are in chronic pain. No, I know from experience that when you don't have the tools and these patients come in, it's frustrating, and you hate to you see the name on the schedule and you're like, I don't want to. I want to take that away, and I want to make practice more fun, because when you're like, I got this.
Yeah, and well, guess who else knows that you feel like that? The patient. And guess what that does to their chronic pain? Makes it worse.
Yeah. If you're not wanting to see them, they're not going to get better.
Yeah, exactly. So speaking of the patient, if a patient with a long-standing treatment-resistant pain syndrome was listening to this right now, what would be a message of hope that you would want to share with them and hope that they hear?
Yeah, the tools exist. The tools are out there already to make life better. I've had more experiences than I can count. Patients who don't believe that they can get past where they're at, that are taking painkillers every day just to survive, who can't go get the groceries, who can't sometimes be out of bed for more than a couple of hours a day. Patients get up, they put the kids off school, they go back to bed for 8 hours, they get up, they get the kids home from school, they go back to bed for 8 hours. I mean, these kind of patients exist, and they don't have to live that way anymore. The hope is real. It's absolutely real.
Yeah, absolutely. And somebody with the skills developed from your course can kind of take that hope and translate it into a reality.
Yeah. No, I'd love to see it where we had a directory of the doctors who have taken the program and say, okay, you got a chronic pain, well, over to here. That would be amazing.
I will submit that to the boss and see what she has to say about that, but I think it's a great idea as well. Well, Dr. Hoffman, thank you so much. As we kind of said in the beginning of this, it's Pain Awareness Month, and I think you brought a ton of awareness to things that might have been kind of hidden secrets or hidden knowledge from both patients and both doctors that are watching this. So thank you for shedding a little light on those things, and thank you for putting together all the academic programs that you do to help doctors help patients better. You should sleep well at night saying, hey, listen, I've taught 100 or 200 doctors how to help people better, and each one of those doctors is seeing 1,000 patients. So you're reaching millions of people with the education that you're putting together, and we so appreciate you. Yeah, exactly. Well, thanks everybody for listening. And if you have any questions, or if you want to learn more about Dr. Hoffman's program, of course, you can go to the carrickinstitute.com. Patients, if you're listening to this and you want to find a doctor who's trained in this, on the Carrick Institute's website, there's a spot for patients to find more information. We can always direct you to either Dr. Hoffman or someone who's taken one of your programs. So there is hope, and the hope lies within education at the Carrick Institute. So thanks so much, everybody, and we'll talk to you all next time.